So what are the factors? And if you come to pathophysiology, there's two things called preload and afterload. Preload is when your ventricle is relaxing, completely relaxing, diastolic, end diastolic volume and end diastolic pressure. I'll draw a diagram here. So when ventricles are dilating, when ventricles are relaxing, diastoling, the left atrium pushes the blood down, and at the end of the full complete diastole, at the end of the complete diastole, whatever blood is there in the left ventricle, that is called your end diastolic volume. End diastolic volume. This is called preload. This is called preload. At the end of the diastole, how much ever the blood is here in the left ventricle is called your end diastolic volume. That is also called as preload. So end diastolic volume and end diastolic pressure is that is the one which dictates the cardiac output. So cardiac output basically depends on EDV, preload, and afterload. Afterload is when the heart is contracting. When the contracting, that depends on your left atrial pressure. Left atrial pressure is normal. The same blood will come here. Same blood will come back to the left ventricle. So this is preload and this is afterload. So your pumping capacity depends on number one, preload, number two, afterload, number three, your myocardial contractility. Myocardial contractility. So these are the three factors which maintains your normal cardiac output. So any of these three factors are getting disturbed, the patient may go into, the heart may go into failure. But then there are some normal physiological countercurrent mechanisms which try to support your cardiac output. Suppose your heart is now failing for some reason, not able to pump out. So there are some compensatory mechanisms. Then actually the heart rate becomes more, and the heart tries to reduce the blood supply to the blood vessels. Try to reduce the blood supply to the less important parts of the body. The only vital organs blood is supplied in more quantity. So the tachycardia is one of the compensatory mechanisms. Only when these compensatory mechanisms fail, the patient will become symptomatic. That's why sometimes when you're seeing a patient there, patient sitting in the bed, and if you see the monitor, the heart rate will be 110, 120. This is resting tachycardia. That means his heart is going to fail. So you should not ignore anybody having resting tachycardia. So tachycardia is a early compensatory mechanism before heart really goes into the real failure stage. So you should understand what is preload and what is afterload. As I said, preload is volume and pressure in ventricles at the end of the diastole, and afterload is volume and pressure at the beginning of the systole. There's a slight difference is there. So I'm sure you all have read about Starling's law in physiology. The more the muscle is stretched, the more is the contraction, the more is the ejection. It's like your left ventricle is like a rubber band. The more you stretch and leave it, more fast it comes back and hits to you. So it's like a rubber band. When your left ventricle is stretching more, it contracts also more and it ejects more. That is the Starling's law. Frank Starling's law. And these are the three factors you should remember always: preload, afterload, and myocardial contracted. So what are the types of heart failure? What are the types of heart failure? There are different classifications. One is the structural related classification. One is it is valvular disease causing heart failure, or it is myocardial disease causing heart failure. In myocardial disease, you have ischemic heart disease, you have inflammation, you have infections of the heart, or you have arrhythmias. There are some arrhythmias, tachyarrhythmias, bradyarrhythmias, which can also lead to heart failure. So structurally, there are two things. One is myocardium related diseases, second is valve related disease, valvular disease. These are the two things. Then in the myocardium, you have a systolic heart failure, which means the left ventricle is not able to pump enough with enough force. And there is diastolic. In diastolic heart failure is a recent thing. Recent in the sense last 15 to 20 years we know about it. Otherwise, we used to think always that the heart failure is only because of the left ventricle not systoling properly. When there's a defect in the diastolic, when the ventricle is failing to relax completely, that is called diastolic heart failure, which is commonly seen in elderly patients, hypertensives, and females. So we have systolic heart failure, diastolic heart failure, and both. Okay. As I said, the compensatory mechanisms are counter-regulatory neurohormonal mechanisms that come into play to prevent to maintain the cardiac output in the initial few days. That's why patients comes to you with exertional dyspnea. Exertional, when they are climbing up the staircase or when they are walking, they get exertional dyspnea. So that is one of the commonest presentation of heart failure. So in a patient who is bedridden, elderly patient, not moving out, the heart failure features may not be there. And the same patient, if you make them walk, they develop breathlessness. So in elderly patients, heart failure, diagnosis of heart failure is a little bit difficult. You should keep that in mind. Unless you make the patient walk, he will not have symptoms and he will not seek medical attention. And these compensatory mechanisms also, the renin, aldosterone, angiotensin system is stimulated, and which causes vasoconstriction. And when vasoconstriction is there, your left ventricle tries to contract more to maintain the cardiac output. These are the initial compensatory mechanisms. Only when these mechanisms fail, the frank heart failure sets in. So the Frank-Starling's law, when systolic volume, stroke volume increases, the end diastolic volume also increases. That is the stretch of the cardiac muscle. Just like the example I told you about the rubber band. When you stretch more, leave it, it will come back with force. And a heart muscle also has some kind of elasticity. And coming to the types of heart failure, you have left heart failure, right heart failure. In the beginning of my talk, I told you there is no isolated left heart or right heart failure. Most of the time they are combined biventricular. So if the disease is beginning in the left side, left ventricle, the cause could be in the left atrium, left ventricle, mitral valve, aortic valve, or any other structures. I'll show you here the left heart failure. When you're there's left heart failure here. One, the cause could be in the left atrium because left atrium has some disease like your atrial fibrillation or something. Therefore, the left atrium is not able to empty the full contents into the left ventricle. That's why the cardiac output is low and patient is in heart failure. Second,